Hello guys, good morning. I welcome you all on Unacademy, India's largest learning platform. Myself, Dr. Nidhi, I am your physiology educator at Unacademy. This is our Telegram page. You can join us. Our page on Telegram is Let's Crack NEET PG. Follow us out there so that you'll get link of each and every classes. This is my page on Unacademy, unacademy.com/@KGMC. Follow me out there so that you will get notification of any upcoming courses of any upcoming paid course or the special class. You will get notification. This is the code Dr. Nidhi. If you want to join any paid course, you can use this referral code to get additional 10% off. I have taken many plus classes, many special classes, so anytime you can join and revise the topic. We are going to have this all India mock test on the on the 17th April 9 a.m. This is for the NEET PG 2022. If you are targeting this one, you can definitely join this all India mock test because it is a benchmark for your performance. For that, you have to use the code that is Dr. Nidhi. To unlock the code, this test, you have to apply the code that is Dr. Nidhi. So moving further, we are started with this Unacademy Lite for the NEET PG. If you are seeing that you want to give the test series only, you can join this Unacademy Lite, in which you will be able to access all the subject wise tests, system wise tests, full length mock test paper, previous year question and test series curated by the top educator. Good morning, Dr. Harsel. So we are having this grand test also in this for the NEET PG and ICT FMG. So this is available on both Android and your web. We are starting this MBBS Prof 1. So if you are in your first Prof, you can join this batches starting from the 20th April. So the fees for this one is 3-month fee is 5,500 only, but the pre-launch price is 4,950. 6-month fee is 10,000, but the pre-launch price is 9,000 only. 12-month fee is 12,000 and its pre-launch price is only 10,800. So we are started with this auto daily practice paper for all the plus classes. After the plus classes, you will get 5 to 10 MCQ that is taken by your educator. That will be the topic wise that he or she discussed in your previous lecture, and that is going to help you to understand the topic way more better. So we are with the two type of subscription, plus subscription as well as iconic subscription. So first coming to the plus subscription, what all are the benefits? You will be able to access both a live and recorded session. किसी वजह से आपका सेशन मिस हो सकता है तो you will watch the recorded version. You have an opportunity to learn from India's top educator. Live quizzes and live tests are there. From that you can analyze your preparation at any point of time. You have a flexibility. You can study on the device of your choice. आपका फ़ोन हमेशा आपके साथ होता है, फ़ोन से एक्सेस कर सकते हो. If you want to go for the bigger screen, you can go for the bigger screen also. Good morning, Dr. Deepika. We have a question bank which consists of 25,000 plus question, high yield question है, clinical based question and with explanation है. So this is going to be very beneficial for all of you. Good morning, Dr. Soumya. We are having this subscription also, which is the iconic subscription where you get access of India's two best platform, that is Unacademy and the Prep Ladder. So you are going to get all the plus benefit. Like I said, live classes, recorded classes, question bank, live test and live quizzes. Along with that, you get access for the Prep Ladder. In this, you can access the clinical and integrated essential of Prep Ladder, video lecture from the Dream Team, question bank 3.0, rapid revision and snapshot, and you will also be provided with this treasure and dream notes. So if you want to access the Prep Ladder also, go for the iconic subscription, everybody. Good morning, Dr. Suman. They are our FMG December 2021 topper. Coming to the special class feature, they are also free of course, but they are way more special from the YouTube session. How they are special? Because they are always and always live. Live classes are very beneficial. They are interactive. Polls feature are there. From that you can better understand the topic. Raise a hand feature is there. Now you can talk to your educator in the live session. If you follow any educator, you will get notification of their upcoming courses. After the lecture, you can download the PDF and revise it anytime, anywhere. So moving to the batches, we have started with this high yield revision in MCQ batches for the FMG 2020-22. This is starting from the 13th April to the 13th May. 1 month duration का course है. You can join if you are targeting this FMG 2022. So we are starting this high yield theory revision batch also. We are started with this one. So this is for the NEET PG 2022. So if you are targeting this one, you can join this batch. We are started with this doubt clarification batch from the 6th April. All the 19 subjects will be covered. Live sessions will be there. That is going to help you to crack your exam. These sessions are for the INICT NEET PG May 2022 and the FMG June 2022 exams. So this is the subscription fee structure for Plus. This one is the fee structure. For Iconic, we have this fee structure, and for the Light subscription, which is very economical, this is the fee structure. So as per your requirement, you can take your subscription and start your preparation right now. So coming to our revision series, first we are going to revise this GIT. First, coming to the structure and functional relationship of our GIT. So in this first, coming to this layers of GIT, from outside to inside when we are coming, the outermost layer is the serosa layer. After the serosa, we have this muscularis propria. This muscularis propria consists of two muscular layers. The inner one is the circular muscle layer, while the outer one is the longitudinal muscle layer. And in between these two muscle layers, we have this plexus, which is known as the Mitric Plexus or the Orbac Plexus. So this Mitric Plexus and Orbac Plexus is responsible for controlling our GI motility. Do you remember this point? This point is important. This plexus, which is present in muscularis propria, is our Mitric Plexus, and that is controlling our GI motility. After the muscularis propria, we have another layer which is known as the submucosa layer. This submucosa layer also consists of plexus which is known as the Meissner's plexus. This Meissner's plexus is controlling our GI secretion. So GI motility is controlled by Mitric plexus, which is also known as Orbac plexus. Meissner's plexus is controlling our GI secretion. Moving further, after the submucosa layer, we have the mucosa layer. This mucosa layer is further consisting of four layers. That is vascularis, mucosa, lamina propria, basement membrane, and the epithelial layer. So this muscularis layer has no role in GI motility. What does it do? It alters the surface area available for the digestion and absorption. So see, this is the diagram. The outermost layer is the mesothelia, serosa or the fibrosa. After that, we have this muscularis externa. This is the outermost layer, serosa. Then we have this muscularis externa. This muscularis externa consists of inner circular muscle layer, outer longitudinal muscle layer. In between these two muscle layer, we have the plexus, which is known as a Mitric plexus. This Mitric plexus is responsible for, anybody, this Mitric plexus is responsible for, do reply fast. Anyone? This Mitric plexus is responsible for GI motility. Yeah, very true. After the muscularis externa, we have the next layer that is known as the submucosa layer, the third layer. Okay? The submucosa layer also consists of a plexus which is known as, anyone? The plexus present in our submucosa is known as, yeah, that is responsible for GI secretion and it is known as Meissner's plexus. Excuse me. Yeah, very true. And that is responsible for GI secretion. So this Meissner's plexus is controlling the motor part, motor in nature. Well, this Meissner's plexus, this Mitric plexus is motor and this Meissner's plexus is sensory in nature. So moving further to the regulation of our GIT. Our whole GI system is regulated by either the GI hormones or by the enteric nervous system. That is the nervous system that is confined to our GI tract. So we have GI hormones, we have enteric nervous system. First, coming to this enteric nervous system. This enteric nervous system is confined to our GI tract. It is also known as peripheral or the mini brain. So coming to the innervation part, तो इसके innervation की बात करेंगे तो there are Meissner's plexus and Orbach's plexus, which we already discussed. This Meissner's plexus is sensory; it controls the GI secretion. Orbach plexus is motor in function, which is controlling the GI motility. Now coming to the neurotransmitter. The neurotransmitter can be either excitatory or the inhibitory. The excitatory neurotransmitter in our GI tract are acetylcholine and the substance P. Inhibitory neurotransmitter in our GI tract is vasoactive intestinal peptide and the NO, nitrous oxide. Excuse me. Is this clear? So do remember the excitatory neurotransmitter is acetylcholine and substance P. Inhibitory neurotransmitter is vasoactive intestinal peptide and the NO. So moving further, the extrinsic innervation to our enteric nervous system. That is from the autonomic nervous system. So it is going to have both fibers, sympathetic fiber as well as the parasympathetic fiber. So what does the sympathetic nervous system do to our GI tract? Decreases the intestinal motility and the tone, and it causes the contraction of the sphincter. So basically we can say the sympathetic nervous system are inhibitory to our GI role. It is inhibitory to our GI functions. While this parasympathetic nervous system, what does it do? It increases the intestinal motility, it increases the intestinal tone and causes the relaxation of sphincter. So it is facilitatory to our GI function. Is this clear? So moving further to the interstitial cell of Kazan. What is this interstitial cell of Kazan? They are the pacemaker of our GI tract. They are the pacemaker of our GI tract, and this interstitial cell of Kazan is present in the gap junction with the GI smooth muscle, and they are responsible for generating this basal electrical rhythm. This BER is basal electrical rhythm. So moving further to the location of this interstitial cell of Kazal, they are located at the mid body of the stomach along the greater curvature, and in colon it is present in some mucosal border of outer circular muscle layer. So moving further to the diagram, this is the interstitial cell of Kazal, which is our pacemaker of our GID. Now coming to the what all are the basal electrical rhythm. Basal electrical rhythm are the rhythmic fluctuation in the membrane potential of our GI tract. So this basal electrical rhythm is responsible for GI contraction, GI motility. So this basal electrical rhythm is present throughout the GIT except esophagus and the proximal portion of stomach. This basal electrical rhythm, already discussed, they coordinate and form different type of contractile movement in our GIT, like the peristaltic movements. So this basal electrical rhythm in different part of GIT has a different rate. In the stomach, it is 3 to 4 times per minute. In duodenum, it is maximum, that is 12 per minute. In jejunum, this basal electrical rhythm is 9 times per minute, and ileum it is 7 times per minute. So basically we can say this basal electrical rhythm is maximum in our small intestine. Is this clear with everybody? Do reply fast. Is this clear with everybody? Excuse me. So moving further, what does this basal electrical rhythm do? It does not produce the action potential. So what does it do? It only cross the threshold potential. And जैसे ही threshold potential cross हो जाएगा, what happen? Our action potential will be generated, and that is going to cause the muscular contraction. So now coming to the action potential of our GI smooth muscle. It has depolarization phase as well as repolarization. You all know. So this depolarization is due to calcium influx, and the repolarization is due to this potassium influx. So do remember, this basal electrical rhythm is not responsible to produce the action potential. It only cross the threshold potential और उसके बाद अपने आप action potential generate हो जाएगी. So moving further to the different GI movements. First, the food comes to our oral cavity. Here the deglutation occurs. What does this deglutation means? The process of swallowing of food in the mouth is our deglutation. This deglutation consists of a three-phase: oral phase, pharyngeal phase, and the esophageal phase. This oral phase is only and only voluntary in nature. We can control this one, while this pharyngeal phase and the esophageal phase of our deglutation cannot be controlled because it is involuntary in our control. So now coming to the deglutation reflex, how does it occur? So the afferent that is arising from our oral cavity, that is why this cranial of 5, 1, 9 and 10 goes to the medulla. In medulla we have the higher center in the medulla that is present in our nucleus tractus solitarius. So the signal goes to this nucleus tractus solitarius. From there the efferent arises via this cranial of 5, 7 and the hypoglossal nerve, and they are going to cause contraction of the muscles that is related to the swallowing, that is present in our tongue as well as in our pharynx region. Is this clear? So this is the deglutation reflex. So do you remember the higher center is present in our medulla? In medulla we have this nucleus tractus solitarius that has the center for the deglutation reflex. So moving further, the food from the oral cavity will go to the esophagus. In esophagus it is going to have this esophageal motility. Excuse me. The presence of the food in the esophagus is going to activate three types of peristaltic contraction in our esophagus: primary peristaltic contraction, secondary peristaltic contraction, while third one is the tertiary peristaltic contraction. First, coming to this primary peristaltic contraction. This primary peristaltic contraction is the physiological in nature. Next is it starts immediately after the swallowing, and it is physiological in nature, and it is progressive, means it pushes the food forward. Okay? While the secondary peristaltic contraction is due to irritation of esophagus, and it is also progressive in nature, means it also pushes the food forwards, while the tertiary peristaltic contraction is the non-progressive in nature because it doesn't push the food forward. So we have this third peristaltic contraction in our esophagus, which is a non-progressive in nature. So since it is a non-progressive in nature, it leads to this esophageal spasm. So this is about the esophageal motility. Now moving to the peristalsis. How this peristalsis occur? What is this peristalsis? Peristalsis is nothing. It is a reflex contraction of our GI wall to the stretching which is caused by the food. So this reflex contraction is the peristalsis. So this peristalsis is due to enteric nervous system only. So how does it work? See, when there is a food, there will be the stretching, and due to the stretching, what happened? The serotonin is released. This serotonin is going to activate the Mitric Plexus. This Mitric Plexus is responsible for anybody? अभी just discuss किया था. This Mitric Plexus is responsible for our GI motility. So how it is responsible? We will discuss this one. So release of serotonin is going to activate this Mitric Plexus. So this Mitric Plexus is going to activate the cholinergic neurons. So what happened? The cholinergic neurons in the retrograde direction will be activated. In the anterograde direction, it is also activated. So what happened? The retrograde direction, it is going to release this substance P and acetylcholine. This is a which type of neurotransmitter? Anybody? Which type of neurotransmitter it is? Do reply fast. Yeah, way true. It is an excitatory neurotransmitter. So it is going to cause this retrograde contraction. So retrograde direction में क्या होगा? Excitatory neurotransmitter release हुआ तो retrograde direction में contraction होगा. That is going to push the foot forward. While in anterograde direction जैसे neuron activate होगा, it is going to release this vasoactive intestinal peptide and the ATP. They are basically our inhibitory neurotransmitter. So it is going to cause a relaxation in enterograde direction. So there will be the enterograde relaxation. And due to this enterograde relaxation, there will be the receiving of food. Excuse me. So moving further to this diagram, this is the food bolus. This is the retrograde direction. This is the enterograde direction. So in retrograde direction, there will be release of substance P and acetylcholine. That is going to cause the contraction. That is going to push the foot forward. And in anterograde direction, there will be the relaxation. That is going to cause this receiving of food. Hello, doctor. You can follow us on Telegram page. Our Telegram page is Let's Crack NEET PG. You will get notification of each and every classes out there. Is this clear? So moving further. So now coming to the clinical aspect. So when there is absence of NO, or you can say absence of inhibitory neurotransmitter is there. So whenever there is an absence of this inhibitory neurotransmitter, so there will be no relaxation in enterograde direction. Only and only the action of acetylcholine is there. So there will be unopposed action of this acetylcholine is there. That is going to cause sustained contraction of lower esophageal sphincter. And that is going to cause this achalasia cardia, which is a type of a motility disorder. So now coming to the treatment part, what is the cause of this achalasia cardia? The action of acetylcholine. So we can give the substance that is going to inhibit the acetylcholine, like the botulinum toxin. So this is important. This clinical integration part is important. Do remember everybody. अभी तक सेशन में किसी को कोई डाउट है तो क्लियर कर सकते हैं? Yeah, way true. We can give this substance that is going to inhibit this acetylcholines. किसी को भी कोई डाउट है तो क्लियर कर सकते हैं? So moving further, the food from esophagus is going to go to the stomach. And in stomach we have this gastric motility. In the stomach we have two type of motility. First one is receptive relaxation. Second one is the retropulsion. First coming to this receptive relaxation or gastric accommodation. What happened? The food when reaches to the stomach, the proximal portion of the stomach undergo relaxation. That is going to cause this storage of food. ठीक है? Next is the retropulsion. This retropulsion would happen sorry, when food reaches the pylorus part, the pylorus get closed, and that is going to cause this backward movement of food. Again, the food move toward this proximal part of stomach. So that is going to cause this backward movement of food, and that is going to help this mixing and grinding of food. So there is a two movement. One is pushing the food, the stomach. Second one is retropulsion. When food reaches the pylorus part, the pylorus get closed, and that is going to cause this again movement of food in the stomach. That is going to help in mixing and grinding movements. No, you cannot get this presentation. You have to make your own notes. So moving further to the gastric emptying, the most important part, जैसे काफी सारे questions आते हैं. What is this gastric emptying? Excuse me. What happened? The food from stomach goes to the duodenum is known as gastric emptying. So this gastric emptying is controlled by this pylorus part of stomach. So what is the factor that is going to increase the gastric emptying? There are factors that is going to cause decrease in this gastric emptying. First, coming to the factor that is going to increase this gastric emptying is increase in stomach volume. Next is the important one. The hormone that is responsible for the gastric emptying is gastrin hormone. Delay in gastric emptying of food is transport to the duodenum. No, delay means there is no emptying of food from the stomach to the duodenum. So food will be staying in the stomach for the longer duration in the delay part. Is this clear, Dr. Arun? Carbohydrate rich diet is going to increase this gastric emptying. Now coming to the factor that decreases this gastric emptying. The most important one out here is the enterogastric reflex. So what happened? जैसे unabsorbed carbohydrate, fats and the protein in the duodenum is more, there will be the hyperosmolar state of the duodenum, and that is going to cause this enterogastric reflex. So what happened? When the hyperosmolar state of this intestine is there, the gastric emptying is delayed, and this is known as enterogastric reflex. So do remember, this enterogastric reflex is due to this hyperosmolar state of the duodenum. Is this clear? So next is the hormone that is responsible for the enterogastric reflex are cholecystokinin, secretin and gastric inhibitory peptide. Okay. Hormone that is responsible for delaying in the gastric emptying are cholecystokinin, secretin and the gastric inhibitory peptide. Anybody, which is the hormone that is causing increase in gastric emptying? Anyone? Do reply fast. The hormone that is going to increase the gastric emptying is, no, it is not a vasoactive intestinal peptide, it is gastrin hormone. Very true. Okay. The hormone that is delaying the gastric emptying are cholecystokinin, secretin, gastric inhibitory peptide. Next, the carbohydrate rich diet is going to increase the gastric emptying. Protein and fat rich diet is going to decrease the gastric emptying. So moving further to the small intestine. From stomach, the food is going to reach this small intestine. So in a small intestine, the motility is small intestine motility. So it is basically of two types, peristalsis and the segmentation. So this peristaltic movement is progressive in nature. So it means it is going to push the food forward. While the segmentation is non-progressive in nature, means it is not going to push the food forward. So what does this segmentation do? What happened? the segment that is present before and after the food particle undergo the contraction, and that's why the food movement is retarded. So this retardation of food movement is going to give the adequate time for the digestion and absorption, and this is the segmentation, which is the non-progressive in nature. Is this clear with everybody? In segmentation, what happened? The part of the intestine before and the food after the food particle undergo contraction. That's why the food movement is retarded, and that give the adequate time for the digestion and absorption. So this is basically non-progressive in nature. So see, this is the diagram. This is the food particle. So segment before and after this food particle undergo the contraction, and that causes this giving the adequate time for digestion and absorption. So this is non-progressive in nature. So moving further, our food from small intestine is going to reach the large intestine. In large intestine, we have this large intestinal motility. And this first one is the ostration or the mixing movement. So what happened in ostration? The longitudinal muscle and the circular muscle layer both undergo combined contraction, and this is predominant in colon region, and that's help in the absorption of water and the electrolyte in the large intestine. Next is the mass movement. This is important from the exam point of view. This is basically observed in the colon region. So what happened? This is seen after the meal 3 to 4 times a day after the meal. It is seen, and each contraction lasts for 3 minutes, and this is more predominant in infants. Let's take it and see. This is known as gastrocolic reflex or the duodenocolic reflex. This gastrocolic reflex or duodenocolic reflex is a type of a mass movement. It is more predominant in the infants. Okay? And this enterocolic reflex, duodenocolic reflex is due to stimulation of parasympathetic nervous system. This parasympathetic nervous system is, anyone? This parasympathetic nervous system is facilitatory to our GI function. So what happened due to this gastrocolic or duodenocolic reflex? When food reaches to the stomach, the colonic movement starts. So see, it forces the fecal matter into the rectum. There will be rectum defecation, distension, and that is going to cause this defecation. Okay? So when food reaches the stomach, the colonic movement starts, and this is a type of a mass movement which is more predominant in infant. So that's why what happened when we feed an infant, defecation often follow a meal. That is due to this gastrocolic or the duodenocolic reflex. Is this clear with everybody? समझ में आया दोनों reflex? We have this enterogastric reflex, we have this gastrocolic reflex. Is this clear with everybody? Do reply fast. So moving further, same thing is written out here. This gastrocolic reflex is more predominant in infant. Food in the stomach activate the colonic movement that causes defecation. So in infant, defecation often follow a meal, that is due to this gastrocolic reflex. And this gastrocolic reflex is coordinated by this gastrin hormone. So moving further to our GI secretion, most important part. So coming to the secretion, first of all a little bit of introduction. देखो GIT में जो total secretion होता है वो होता है 9 लीटर का. Out of this 9 liter, 8.8 liter is reabsorbed, while 20 ml is excreted in the stool. So GI secretion basically consists of our saliva, gastric secretion, pancreatic secretion, biliary secretion, and intestinal secretion. Among this all, the salivary secretion are neutral in pH, while this gastric secretion is the most acidic one, and its pH ranges from 1.5 to 3. While the pancreatic, biliary and intestinal secretion are alkaline in nature. Among these all three, the most alkaline is our pancreatic secretion. So moving further to the salivary secretion. Per day secretion of saliva is 1.5 liter. Its pH is 7. Its tonicity is hypotonic to the plasma. Now coming to the sources of salivary secretion, we have major salivary gland, we have this minor salivary gland. The major salivary glands are parotid gland, submandibular gland and the sublingual gland. So see, this is the diagram. In front of EO we have this parotid gland. Below the mandible we have this submandibular gland. This is our mandible, and below this mandible we have this submandibular gland, and below this tongue we have this sublingual gland. So do remember, the 70% of saliva is secreted from this submandibular gland, 10% is secreted by the sublingual gland. So minor salivary gland like von Ebner's gland are basically present in the palatal region. So moving further, the acini से जो हमारा saliva secrete हो रहा है, that is isotonic, because the sodium, potassium and chloride and the bicarbonate level are close to the plasma. Well, in duct, what happened? The ductular modification occur. In ductular modification, what happens? Sodium and chloride is extracted from the saliva and potassium and bicarbonate is added into the saliva. This process is known as the ductular modification that occurs in the duct of salivary gland. So in acini portion, the saliva which is secreted is isotonic. In duct, the ductular modification occurs. Sodium and chloride is reabsorbed, while potassium and bicarbonate is added into the saliva. This process is known as ductular modification. See, sodium and chloride is extracted from the saliva, and this potassium and bicarbonate is added in saliva. This process is known as ductular modification. So moving further, in Siluria disease, what happened? This ductular modification is not seen. So now coming to the digestive enzyme. The digestive enzyme that is present in our saliva are salivary amylase, which is also known as a ptyalin. Lingual lipase, that is coming from the von Ebner's glands, are the digestive enzyme. Now coming to the immunological function of saliva. Lysosome basically attack the bacterial cell wall. Lactoferrin prevent the multiplication of bacteria, and binding glycoprotein for the immunoglobulin A is there in our saliva. So do remember, our salivary amylase is responsible for carbohydrate digestion. So this carbohydrate digestion starts from our saliva. This lingual lipase has basically no role, that is coming from our salivary glands. So that is von Ebner's gland, that is a minor salivary gland. The major role is played by the salivary amylase. So moving further to the autonomic regulation of the saliva. So what does this parasympathetic nervous system do? It causes increase in saliva, but the saliva out here is a thin watery saliva. What does the sympathetic nervous system do? It also increases the saliva, but the saliva out here is a thick saliva. So this is the important part to remember, everybody. So moving further to innervation of our salivary gland. So the parotid gland is innervated via this otic ganglion, which is coming from this cranial nerve 9. Our submandibular gland and the sublingual gland is supplied by the submandibular gland. So do remember, the parotid gland is supplied by this otic ganglion, and submandibular gland and the sublingual gland is supplied by the submandibular ganglion. So this is the important note. Highest potassium secretion per day is for the saliva. Highest potassium concentration is for the colonic fluid and the rectal fluid. Concentration की बात करेगा तो it is colonic fluid and the rectal fluid. Secretion की बात करेंगे तो it is saliva. Is this clear with everybody? So moving further, after the salivary secretion, we have this gastric secretion that is released from our stomach. The total secretion per day is 2.5 liter. It is the most acidic one. Its pH is 3. The source is the gastric gland, which is a flower shape. ठीक है. Parietal cell is responsible for gastric acid and intrinsic factor of acid, and peptic cell is responsible for production of pepsinogen. Next is the G cell, which is present in the antral region, and that is responsible for this gastric hormone production. So see, this is the diagram. This is the our gastric gland, which is a flower-shaped cell. It consists of the outermost layer, that is a mucus layer, mucus cell, which is going to cause this production of a mucus, which is a bicarbonate rich, that is going to help in acid neutralization. So this is the mucus cell. Next is the next cell, which act like a stem cell. Next is the parietal cell, which is going to produce this acid and intrinsic factor of acid. Am I audible to all of you? I guess I am audible. Let me check. Do reply fast. Am I audible? Okay, fine. So we are here now. So outermost layer, the mucus cell layer, that is going to produce the mucus, which is a bicarbonate rich, and that is going to cause this acid neutralization. Next is the next cell, that is acting like a stem cell. Next is the parietal cell, that is going to produce this acid and intrinsic factor of acid. Next is the enterochromaffin-like cell, which is going to produce the histamine. Next is the chain cell, which is going to produce the pepsinogen, and it is also known as peptic cells. And we have the next, we have this G cell, which is present in the antral region, and that is going to produce this gastric hormone. So moving further to the clinical aspect. So whenever the autoantibodies form against this parietal cell, that is known as anti-parietal cell antibody. So in this situation, what happened? The gastric acid is not produced, intrinsic factor of acid is not produced. So that is going to cause this achlorhydria, means no acid is seen. And that is going to cause this anemia, in which we have this vitamin B12 deficiency. And this is known as a pernicious anemia. So wherever there is an autoantibodies form against this parietal cell, it is going to lead this pernicious anemia. Excuse me. So moving further to the next important part, how the gastric acid is produced. So see the diagram very carefully. We have this gastric acid parietal cell. We have this blood part out here. We have this gastric lumen out here. So this end of the parietal cell is known as basolateral end, because it is near the blood vessel, and opposite end is known as apical end. So what happened due to metabolism? There will be the production of carbon dioxide inside the parietal cell. So this carbon dioxide react with the water molecule in the presence of carbonic anhydrase, and it's going to cause this formation of carbonic acid. This carbonic acid is associated to form H plus ion and this bicarbonate ion. This H plus ion is taken inside the GI lumen via this hydrogen potassium pump. And this bicarbonate is added into the blood via this bicarbonate chloride exchanger. So in exchange, what happened? The chloride ion move inside the parietal cell. This chloride ion goes to the GI lumen. It combined with this H plus, so it is going to form this hydrochloric acid. So this potassium ion which enter into this parietal cell is also having this basolateral end. Where our sodium potassium pump is there, that is going to push the sodium back into the blood, and that is going to cause this again potassium inside the cell. So this is the basic part of our GI, our hydrochloric acid production. So in this, what we all are seeing, with each molecule of acid form in our lumen, one bicarbonate is added into the blood. So we can say after having a meal, the hydrochloric acid will be produced. So after having a meal, there will be increase in the alkalinity of a blood. And this is known as a postprandial alkaline tide. Is this clear with everyone? This postprandial alkaline tide, is this clear? So what happened after each meal, with the formation of one molecule of hydrochloric acid, a bicarbonate is added into the blood, and that is going to increase the alkalinity of blood, and this is known as postprandial alkaline tide. Is this clear everyone? Do reply fast. किसी को भी कोई डाउट है तो क्लियर कर सकते हैं. Okay, fine. Moving further. So same thing is written out here. For every hydrochloric acid production, bicarbonate is pushed into the blood. So after food intake, there will be this postprandial alkaline tide. So moving further to the next important part, the agent that is going to alter this hydrochloric acid secretion. There are some factors that is going to increase the acid secretion. There are some factors that is going to cause a decrease in acid secretion. First, coming to the factor that is going to cause this increase in acid secretion are, do remember this is very, very important. It is histamine, which act via H2 receptor, the gastrin, which act via cholecystokinin B receptor, and the acetylcholine, which act via this M3 receptor. They all are going to increase this acid secretion. Okay, now coming to the factor that causes decrease in acid secretion are excess acid via the negative feedback. Somatostatin, which is a universal inhibitor, so it is going to inhibit the acid production also. Prostaglandin, secretin hormone. So do remember, the gastrin hormone is going to increase the acid secretion. The secretin hormone is going to decrease this acid secretion. Is this clear with everybody? The hormone that is going to increase the acid secretion is gastrin. The hormone that is going to increase the acid secretion is secretin. So this is the diagram, which is very important. When vagus nerve is activated, acetylcholine is released. Acetylcholine acts via the muscarinic receptor, M3 receptor, and it is going to cause increase in acid production. Next is the mast cell. When mast cell is stimulated, histamine is released. This histamine via the H2 receptor is going to cause increase in acid production. When G cell is stimulated, this gastrin hormone is released. This gastrin hormone acts via this cholecystokinin B receptor, and it is going to cause increase in acid production. Is this clear with everybody? So moving further to the clinical part, when we give this NSAIDs. NSAIDs are basically the prostaglandin blockers. So what does this prostaglandin do? It is going to decrease the acid production. So out here, what happened? The acid is going to increase, and that is going to cause this peptic ulcer. So that's why when we give this NSAID, the most common side effect when we give this long-term NSAID is our peptic ulcer. Because NSAIDs are prostaglandin blockers, so the acid production increases. So that's why the most common side effect is peptic ulcer. Is this clear with everybody? So moving further to the phases of this gastric acid secretion. There are three phases: cephalic phase, gastric phase, and the intestinal phase. Now coming to the first one, that is cephalic phase, which is contributing 20% of our acid production, and that starts with the only sight and smell of food, and this is mediated by the vagus nerve. Next is the gastric phase, which is mediated by this gastrin hormone. So it is responsible for 60 to 70% of acid production, and this gastric phase is mediated by distension of stomach wall mechanically and due to the protein breakdown product, that is due to this chemically. So it is either by the mechanical method or the chemical method, the gastric phase is there. In this we have 60 to 70% production of our gastric acid is there. Next is the intestinal phase, which is responsible for only 10% production of gastric acid. It is mediated by this gastrin hormone. So now coming to the digestive role of this gastric secretion. So in a stomach we have no enzyme for carbohydrate digestion. For lipid digestion we have gastric lipase. For protein digestion we have this pepsinogen, which is converted into its active form pepsin. In lower animals the protein digesting enzymes are renin. So moving further to the pancreatic secretion, when food reaches the small intestine, it is going to encounter with this pancreatic secretion. This pancreatic secretion pH is 8.3 and it is the most alkaline GI secretion. When coming to the tonicity, it is isotonic to the plasma. Protein content is highest. So now coming to the digestive role of pancreatic secretion, we have this pancreatic amylase for the carbohydrate digestion. We have this pancreatic lipase for the lipid digestion. So moving further, for protein digestion, the enzyme that is coming from our pancreatic secretion are trypsinogen, chymotrypsinogen, procarboxypeptidase and the aminopeptide. In this trypsinogen and chymotrypsinogen is a endopeptidase, while this procarboxypeptidase is our exopeptidase. Excuse me. What do you mean by this endopeptidase or the exopeptidase? This endopeptidase means, suppose this is the amino acid chain or the protein chain. What does this endopeptidase do? It breaks the bond from the interior region. So that's why the dipep or tripep will be formed. This is the endopeptidase. What does this exopeptidase do? Exopeptidase break the bond from the exterior region, and that is going to cause the formation of free amino acids. Is this clear? So all the enzyme that is coming from our pancreas are in the form of zymosin, means they are present in inactive form. So why they are present in active form? Because to prevent the autodilatation of pancreas, the pancreatic enzyme, the pancreatic protein digestive enzyme are present in its zymosin form. So how they are activated? Trypsinogen is converted into the trypsin in the presence of enterokinase. This enterokinase is coming from the small intestine. That is responsible for this conversion of trypsinogen into the trypsin. So next is a very, very important part, that is the regulation of this pancreatic secretion. So first is the secretin hormone. This secretin hormone acts on the ductular portion of pancreas, and that is going to cause increase in bicarbonate rich secretion coming from pancreas. So they are basically helping in acid neutralization that is coming from our stomach. Okay? So the secretin causes bicarbonate pancreatic rich secretion. Next is the cholecystokinin pancreozymin. As the name suggests, the pancreozymin means it is going to cause more secretion of enzyme from the pancreas. So they basically act on the acinar portion, and they are going to cause increase in enzymatic secretion. Next is the acetylcholine. It stimulates the enzyme secretion from acinar. It is also going to potentiate the effect of secretin. What does secretin do? It causes bicarbonate rich secretion. So this acetylcholine has both action of secretin as well as pancreozymin. Is this clear? So moving further to the diagram, this is the acinar portion of pancreas, this is the ductular portion. On ductular portion, the hormone that is acting is the secretin hormone, which is going to cause this bicarbonate rich secretion. On acini, the cholecystokinin pancreozymin act. So this is going to cause enzymatic rich secretion from the pancreas. So enzyme that is present in pancreas are pancreatic amylase, pancreatic lipase, nucleases, proteases like trypsin, chymotrypsin, elastase and the carboxy peptidase. Is this clear with everybody? अभी तक सेशन में किसी को कोई डाउट, anyone, any query till now you can ask. So we have colorectic, the substance that is going to increase the biliary secretion. We have cholangitis, substance that causes contraction of gallbladder and that causes the release of this bile. The most important colorectic is the bile salts. Bile salt itself causes increase in this biliary secretion. Secretin hormone is going to increase the biliary secretion. Remember, the secretin hormone was decreasing the gastric secretion, but this is increasing this biliary secretion. Vagal stimulation also increases the biliary secretion. Now coming to the cholangitis, the most important cholangitis are cholecystokinin. Is this clear with everybody? Do reply fast, everybody. Is this clear? Okay, moving further. This is the item already discussed. Coming to the intestinal secretion. The intestinal secretion is also known as succus entericus. This is secreted by the crypt of liver cones. This is the crypt of liver cone. This consists of goblet cell, which is the surface cell which is going to produce the mucus. It consists of epithelial cell that is responsible for GI secretion, and it consists of the Paneth cell. So see, this intestinal secretion also contains this enterokinase, which is going to activate this trypsinogen. So the goblet cell is the first cell, which is the surface cell that is going to produce this mucus. Epithelial cell that is going to cause this GI secretion, that is succus entericus is released. Next is the Paneth cell, which is present at the base of crypt of liver cone cell, and that is going to increase the concentration of zinc that secretes this defensin and the lysosome part. So moving further to the question part, first question of today's session, basal electrical rhythm is produced by option A, smooth muscle at the cardiac end of stomach, antral G cell, interstitial cell of Casal, or the Mitric Plexus. Everybody answer this question. Basal electrical rhythm is produced by do reply fast, everybody. This basal electrical rhythm is produced by it is produced by this interstitial cell of Basal. Next, function of Mitric Plexus is absorption, GI secretion, basal output, or the motility. Mitric Plexus is responsible for everybody do reply fast. The function of Mitric Plexus is this Mitric Plexus is responsible for GI motility? Answer is the D. Coming to the next one, in infant, defecation often follow a meal. The cause of colonic contraction in this situation is gastroileic reflex, enterogastric reflex, increased circulating level of cholecystokinin, or the gastrocolic reflex. In infant, defecation often follow a meal. It is due to. Do reply fast, everybody. In infant, defecation often follow meal. That is due to this gastrocolic reflex. Very true. Coming to the next one, slow wave or basal electrical rhythm is maximum in stomach, ileum, colon, or the rectum. Basal electrical rhythm is maximum in everybody answer this question. Slow wave or basal electrical rhythm is maximum in. Yeah, way true. The basal electrical rhythm is maximum in a small intestine, that is ileum. Coming to the next one, stimulation of gastric emptying is done by secretin, cholecystokinin, gastrin, or the distension. Stimulation for the gastric emptying is everybody answer this question. Stimulation for gastric emptying is gastrin hormone to stimulate the gastric emptying. Distension also stimulate the gastric emptying. So answer is both the C and D. No, cholecystokinin delay the gastric emptying. Secretin hormone delay the gastric emptying. Answer is only C and D. Coming to the next, that is which of the following substance causes enterogastric relaxation during gut peristalsis? Acetylcholine, substance P, serotonin, or vasoactive intestinal peptide. Enterograde relaxation is done by. Everybody answer this question. Yeah, it is a vasoactive intestinal peptide that causes enterogastric relaxation. Very true. Coming to the next one, the pacemaker of GIT is located in the cardiac end of the stomach, pyloric end of the stomach, central control of CVD duration, or the fundus of the stomach. The pacemaker of GIT is located in yeah, very true. It is present in the cardiac region of stomach. Coming to the next one, the enterogastric reflex is stimulated by all except alkaline content of small intestine, hyperosmolarity of a kind, distension of duodenum, or none. The enterogastric reflex is stimulated by all except. Everybody answer this question. Enterogastric reflex is due to enterogastric reflex is stimulated by all except it is stimulated by not stimulated by the alkaline content of small intestine. It is answer is A. Is this clear with everybody? Coming to the next question, which of the following is true regarding gastric emptying? It is decreased by cholecystokinin, decreased by gastrine, increased by secretin, decreased by insulin. Which of the following is true regarding gastric emptying? Everybody answer this question. Everybody answer this question. Gastric emptying. Which of the following is true regarding gastric emptying? Gastric emptying is delayed by the cholecystokinin, increased by the secretin, decreased by the secretin, no action by the insulin. So answer is only and only A. Is this clear? Coming to the next question. Chyme is propelled forward in the small intestine by segmentation, ostration, MMC, or the peristalsis. Chyme is propelled forward in a small intestine by. Everybody answer this question. No, it's not MMC. MMC is seen in large intestine and it is a progressive one also, but it is seen in large intestine. Chyme is propelled in a small intestine. In a small intestine, we have two movements, peristalsis and segmentation. Segmentation is a non-progressive in nature, while the peristalsis is only and only progressive one. So it is going to propel the food. So answer is D only. Is this clear with everybody? So moving to the next question, all of the following statements are true for the intestinal motility except doesn't depend upon the gastric motility increased by distension, increased by acetylcholine, increased by cholecystokinin. All of the following statements are true for intestinal motility except. Everybody answer this question. Everybody answer this question. All of the following statements are true for intestinal motility except. Intestinal motility depend upon this gastric motility. We have this enterogastric reflex. So answer is A. Is this clear with everybody? Coming to the next question, the longest transit time in GIT is seen in stomach, jejunum, colon, or the ileum. The longest transit time in the GIT is seen in. Everybody answer this question. The longest transit time in the GIT is seen in. The longest transit time in GIT is seen in. The longest time transit time in GIT is seen in colon. Do remember. Answer is C. Coming to the next one. Which of the following is an inhibitor for the gastric acid secretion? Acetylcholine, gastrin, histamine, or the secretin? Everybody answer this question. Everybody answer this question. Which of the following is an inhibitor of gastric acid secretion? Acetylcholine, gastrin, histamine, all are going to increase the gastric acid secretion. Only and only secretin decreases the gastric acid secretion. So answer is D. Coming to the next one, intrinsic factor of Castle is secreted by which of the following cell in the gastric glands? The chief cell, the parietal cell, enterochromaffin cells, or the B cell. The intrinsic factor of a Castle is secreted by which of the following cell in the gastric gland? Everybody answer this question. Intrinsic factor of Castle is secreted by which of the following cell in the gastric glands? Intrinsic factor of Castle is secreted by this parietal cell or onsentic cell. Answer is B. Coming to the next one, the parietal cells secrete the mucus, pepsinogen, gastrin, or intrinsic factor. Already discussed, skip karte hain. Coming to the next phase, next question, the cephalic phase of gastric secretion is 20%, 70%, 10%, or the 100%. Cephalic phase of gastric secretion is cephalic phase of gastric secretion is intrinsic factor of gas. Okay, 1 minute. The cephalic phase of gastric secretion is R 20%. Answer is A. 70% is during the gastric phase, and 10% is during the intestinal phase. Coming to the next question. In the stomach, H plus ion are secreted in exchange for sodium, potassium, calcium, or the chloride. In the stomach, H ion are secreted in exchange for everybody answer this question. In the stomach, H ion is secreted in exchange for it is secreted in exchange for potassium ion. Coming to the next one, which inhibit the gastric secretion, secretin, insulin, high gastric pH, or the calcium? Which inhibit the gastric secretion? Which is going to inhibit the gastric secretion? Secretin hormone is going to inhibit the gastric secretion. Coming to the next one. Gastric secretion is increased by all except histamine, acetylcholine, gastrin, or the hydrochloric acid. Gastric secretion is increased by all of the following except everybody answer this question. Gastric secretion is increased by all of the following except it is increased by all of the following except hydrochloric acid give the negative feedback, so that is going to inhibit the gastric secretion. So answer is D. Coming to the next one. Cephalic phase of gastric secretion is on food entering stomach, food entering intestine, on seeing food, on stress. Cephalic phase of gastric secretion is due to everybody answer this question. Do reply fast. Cephalic phase of gastric secretion is with cephalic phase of gastric secretion is on seeing the food only, on the smell of food, on seeing the food, the cephalic phase starts. Coming to the next question. Hydrochloric acid secretion in the gastric phase is increased by pepsinogen, cholecystokinin, gastrin, or the secretin. Everybody answer this question. HCl secretion in gastric phase is increased by the gastrin hormone. Coming to the next one, hydrochloric acid secretion is stimulated by the secretin, somatostatin, histamine, gastrin, or vasoactive intestinal peptide. So this question contains multiple answers. So everybody see each an option very correctly. Hydrochloric acid secretion is stimulated by HCl secretion is stimulated by histamine and the gastrin hormone. Both stimulate this HCl secretion. Coming to this one, highest concentration of potassium is seen in bile, pancreatic juice, terminal ileal secretion, or the rectal fluid. Highest concentration of pancreatic secretion is everybody answer this question. Highest concentration of potassium is in highest concentration of potassium is in rectal fluid. Coming to the next question, the maximum potassium ion secretion is seen in, ठीक है क्वेश्चन में डिफरेंस समझ में आया, Option A, saliva. Option B, gastric secretion. Option C, jejunal secretion. Option D, colonic secretion. Maximum potassium ion secretion is in everybody answer this question. Maximum potassium ion secretion is seen in saliva. जब concentration की बात आएगी then it is colonic fluid or rectal fluid, and secretion की जब बात आएगी तो answer is saliva. Is this clear with everybody? Coming to the next question. The most important stimulant for biliary secretion is cholecystokinin, secretin, bile acid or the bile salt. The most important stimulant for the biliary secretion is the most important stimulant for the biliary secretion is. Question is asking about the colorectics. The most important colorectic is bile salt itself. Is this clear? Coming to the next question, bilirubin is secreted by bile salts, bile pigments, secretin or the cholecystokinin. Bilirubin is secreted by bilirubin is secreted by, it is secreted by bile salts. Answer is A. Very true. Coming to the next question, maximum contraction of gallbladder is seen with the cholecystokinin, secretin, gastrin or the enterogastron. Maximum contraction of gallbladder is seen with maximum contraction of gallbladder is seen with this cholecystokinin? Answer is A. Coming to the next one, the maximum, which of the following secretion has a very high pH? Gastric juice, pancreatic juice, biliary secretion, or the saliva? Everybody answer this question. Which of the following has very high pH? Everybody answer this question fast. Which of the following secretion has a very high pH? Pancreatic secretion is the most alkaline one, so answer is the B. Is this clear? Coming to the next one. Okay, that was the last question of today's session. आज के सेशन में किसी को भी कोई डाउट है कोई सी टॉपिक से तो क्लियर कर सकते हैं. No, it is not the gastric juice. Gastric juice की सबसे low pH होती है. It is the most acidic one. किसी को कोई डाउट? Anyone, any query from the today's session you can ask. Hope you all like this session. If you like this session, do like and share. This is important. जितना ज़्यादा share करोगे, class उतनी interactive होती है. So do share everybody and subscribe our channel. That is the Let's Crack NEET PG. And press the bell icon so that you will get notification of every class and you won't miss a single class. Do press the bell icon, everybody. So you can follow me on Unacademy. My page on Unacademy is unacademy.com/KGMC. You will get the link of this page and in the description box. Also, you can follow us on Telegram. Our page on Telegram is also the Let's Crack NEET PG. You can follow us out there so that you will get link of every classes out there. Okay, that's all for today. Thank you so much for joining. So if you are looking for further classes, follow me out there so that you will get notification of every classes and you won't miss a single class. Regular मेहनत करते रहिए, you will definitely able to achieve your target. You will definitely crack your exam with good rank. That's all for today. Thank you so much for joining. See you all in the next session. Bye bye everyone.